Thanks that I can speak again, and it was a nice presentation before, and we have the same problems like my speaker before say, and for this one we use the stand to bridge also the ureter. What I want to show you is firstly a simple case that was 2 days before. That's why it's better for understanding. It's a typically urology case. You have seen here a treatment after laparoscopic surgery of our surgeons. They take the bowel out and make a ureterolysis. They destroy the ureter, and some guy put a stent inside. But the stent is not closing totally. So they have a urinoma around the kidney. They put then a CT drainage inside, and it is also not closed. You see it now in ureteroendoscopy, the partial damage of 2 centimeters after laparoscopic destroying. A stent don't heal really exact a fistula. That's why we use a fully covered stent. And in these cases, we replace then the stent, or we make it at the first treatment to put a stent inside. This is the same what I say before, also in ultrasound. This is now the stent inside. In the same moment, if you put the stent inside, it's 30 French, the size then. It's 20 centimeter long, and it's 9 millimeters in diameter. Then it's pressing like at a heart stand to the leakage, and it is dry in the same moment. So you have a lot of time to wait for a wound healing. Normally a fistula is closed between 6 weeks to 8 weeks. Then we replace it. This was only a small leakage from 1 centimeter. You asked before how big it was. This was 1 centimeter leakage. Our problem is also to make now a bigger leakage also to bridge, because we have a big series about 60 to 80 fistulas where we covered it with a stent, and it is fully closed. And the history of that stent was that the stent was developed before only for obstruction and strictures, but we use it for partial uretic defects like fistula. Since 2012, we close a lot of them after iatrogenic damages, also after necrosis, tumor necrosis, or after artificial problems with suturing. We saw we have good results, and that's why we changed also to complete ureteric defects. This is the same what he say. If you have a totally lost ureter for a long stricture or a long part, they are cutted or necrosis, we want to bridge it, but transurethral. The mean time to insert a stent is only 30 minutes. And we bridge now areas they are lost of ureter between 1 centimeter to 5 centimeters. And we put it totally 7 times from transurethral, transretrograde, and antegrade in 1 time. And this is also an alternative way, because the normal stents are not working, because we know that a typically stent drainage outside and not all inside. Memocard is not working, resonance stent is not working, and other stents like Uenta has a problem because later they engrafted in the tissue. You have no chance to replace it carefully. And our stent, what we use is covered like with a litinol. It's the same like what you use for your heart. It's a stainless steel skeleton, and litinol, it's really softly, and it's like an umbrella. You can put it then inside. And the second good thing is you can remove it also really carefully and really simple, because you take your forceps on it, and if you pull it, it destroys itself. Then the fully covered and waterproof covering destroy it and you can replace it. With a Uenta, for example, you can do it. We have the same studies look like what my speaker before say, and there are a huge number of studies worldwide, but not with a permanent, fully covered stand. This is one example only of a fistula, and then you understand why we use it then more as the next case. It's a typically urology case. Prostate cancer, metastatic. Later, they make also ureterolysis. They make also a lymph node dissection, a Salvas lymph node dissection. He destroys the ureter. He put a lot of stents in, clips inside, and then in the deepness, he had a fistula nearby the lateral side, on the left side of the iliac wall. And what you see here is, if you show the retrograde viewing, you see the fistula in the deepness. And what we done, and he don't like the double J because he had a double J problem since 1 year, and that's why we want to use now our new stent. The stent is really simple to do. It's like in a typically way to put a stent inside in Seldinger technique. You take a guide wire inside and then you put the stent, and he is pressing itself to the lateral wall from the ureter, and then in the same moment it's closed. What you see here now, the stent is inside, the fluid is coming, and the leakage is closed. This patient will be not healed because we leave this stent then for a long time, for 3 years to 5 years. That's the mean lifetime of the stent, and then you can change it. You can put also a stent inside, because after radiotherapy it's not a good idea to have a good wound healing. If you have a bigger one leakage, this is now our problem. After a big treatment, sigma resection, you have the same cases here. Second or third treatment, sacral recidive of a rectum cancer, they put it and they damaged then the ureter on the side with a big leakage. The leakage here is 2.5 centimeters, and in these cases you have no chance to put a stent, a normal stent, a double J inside. In this kind, we put then a stent inside, the fully covered stent, and it closed. And you see here also on the picture that the stent, it's covering, and because that is a radiotherapy patient, the stent, in this case we use only a 12 centimeter stent. You can put also a typically normal stent for 20 euro inside. We call it then stent in stent technique. The interesting part on these pictures also that you see where is the damage of the ureter. You see the stent and there's pressing like a ball outside. This ball, what you see here, this is the part where is the leakage part of the ureter. And it's covered, and if you see the patient later, they have no fluid inside of the abdomen or no fistula more, because in the same moment it's closed and all it's okay. A fully covered stent and stent in stent technique. Next case for bridging. Malignant melanoma, they treat it in gynae. Also second treatment, they do a total abdominal vaginal colpectomy and he destroys the ureter. And one side, they put a stent inside, on the other side, they haven't any stent inside. And you see it here. I go now with the scope inside of the ureter. The distal part, the first 4.5 centimeters are good. And then they cut it, because after that big treatment they had a leakage, and you see it also in the X-ray that was not nice. Interesting to find it. You have two ways to find it. If you are well trained, you can find it also retrograde. You give some blue fluid, or you find the end of the ureter, there's cut it. We find it now with the scope, we search for it, and we find the upper part of the ureter, and then we put a guide wire inside, and then you close that total bridge. In this case, it was a bridge from 3 centimeters. And if you put the stand inside, you have, it's a better recommendation, because now since 1 year we can use the stand with 20 centimeters. Before they have only 12 centimeters. We use now a 20 centimeters. It's really simple to insert. You see here the X-ray marker on top, and there are the part where we bridge it. And in the same moment, if you put it inside, the stand is like an umbrella. It goes to the ureter, it closes, and the drainage is in the normal way. You have, since that time, no fluid more to the abdomen. And this is the bridging technique, really simple, also in crazy cases, because to replace it and to make a reconstruction after 2 weeks, if a gynae will gun that treatment, it is like you go on the Golan Hills, because it is horrible to make a new implantation. After that case is not possible. So the stand, to put it inside, it's really simple. Next interesting case, big complication, laparoscopic hysterectomy, endometriosis. Typically, they cut the ureter. And to cut the ureter, then we see a big urinoma. In the frontal side, you see the bladder, and you see the big urinoma. But what is interesting, you see here the both sides of ureter. There is cutted, and there's cutted with ultracision, and the distance of the both ureter are 3 centimeters. The kidney is not so hydronephrotic. You see the urinoma and the deepness very well, and now you see both sides of the ureter in ultrasound in the Kung Fu technique. The white spot is the part where the ultracision is cutting the ureter. If you cut a ureter, you see it like hypodensic. You see a normal ureter, and you see also the tip of the ureter, and then you can calculate how long you need to put the stand inside. What we done at first, we check it, it's really a urinoma or not, and then we want to go, what I say before, like the other case, to go retrograde. If you have no chance to go retrograde, because I can't find it really exact the other part of the ureter, because I go the whole time in the urinoma, then I go antegrade also inside of a rendezvous maneuver. You see it here, rendezvous maneuver, 1 guide wire from up, down, we capture it, and then we put a stand exact inside on the side. In that picture you see it nicely, that the both parts of the ureter, there is pressing, there they cut it, there's pressing to the stand. There's really softly the stand, and you see it like a towel, like a woman. And the towel, there is the part, there's a stand, it's captured, it's destroyed. You see here a gap where is bridged over 3 centimeters. And this is, now we leave the stand inside and we wait for 6 to 8 weeks, and when we check it. This is a nice house from a Greece man, he's building near to my house. That's why I want to show it. And so it was 2 days later. The urinoma, it's gone. You see here the space, the gap, only now 1 centimeter. And 8 weeks later, we check the same patient also. You see here the ultrasound in the technique. The stand is really properly inside it, and it is a space, and the stand drainage really exact. 8 weeks later, this is the ureter now. We put the stand outside. The ureter is coming to end without any other treatments, and Then we watched inside, and I show you first the ultrasound picture. This is the ultrasound picture. You don't see any scar. The ureter, it's coming itself from end to end, and it's building not a scar. And we put only the stent out, and this is a normal fluid without any stenosis. You can see it really exact, and you can see it here, how the fluid comes through the ureter without any stenosis. And you can see it here also. With elastography, we have no stricture around. It is the same like you make an end-to-end anastomosis, and sometimes it is better. In ureterorhinoscopy, sorry, we have not so nice, that was an old instrument. You see it here now, that the ureter, it's opening, and only in the area where it's come together, you see small polyps. The interesting part is the litinol, it's like at the cardiac, that's why they use it since the last 30 years for cardiac problems. They don't build any scar around, and that's why we can use it very well. It is small, it is thin, it is pressing to the ureter, and around it's building no scar. We use it also if you have a big gap. A youngster of us changed a double J and crossed a double J after a patient after endometrium cancer and radiotherapy. And she destroyed the ureter and at the crossing of the iliac communis. And what you see here now is what we done also. We put a stent inside if you have a damage of a arterial ureteric fistula. It's closing from the ureteric side in the same moment. It is totally dry, and you can put it inside, and it's covered very well. So that was the case. You see it here. They put a stent inside, and our vessel surgeons said they don't believe it really exact, and they put also a stent from the other side, but here you can see it very well. The stent is covering the ureter, no bloody, and no, it's coming of both sides, and all it's nicely to see. The stent is covering all damages, and it is waterproof, and is in Seldinger technique really simple to put inside it. If you have a big damage after radiotherapy, for example, we have a lot of cases after radiotherapy damage, after coiling of the vessels, and near the coiling is then the ureter, and if the ureter is damaged, then you get also arterial ureteric fistula, or it comes then to a bigger problem. Also, with a big gap for 3 to 4 centimeters, we put then a stent inside, and it's covered. It's only put in Seldinger technique inside, and you see here on the sides the coiling, and then the stent is emplaced. We had a problem with the short stent of it, because from 2012 to 2016 we use only a 12 centimeter stent. The company produced only 12 centimeter stents, and this is a part that can be dislocated. But interesting is it, you see it here, the case, we put the stent inside, it was covered. It is only litinol, and is pressing against the ureteric wall, and the fluid is really exact because the volume of the stent is 1 centimeter. And if you see then inside of the ureter, you see it here, we come now higher, 5 centimeters from the ostium, you see the big damage. 4 centimeter total damage on the side, and it is next stent, what we put it now inside, is a 200 millimeter stent. In the same moment it is dry. It is bridged, and it is simple to emplace. 30 minutes only, and we make the same check also from the ass to see it, because that was a total rectal exenteration, but they damaged the ureter, and after calling and after radiotherapy is not a nice idea. You can put it also on both sides if you have a big damage, and there's no problem. And also in this case, totally bridged after laparoscopic cervical cancer. Both sides of ureter are destroyed. We make it in a bridging, and they destroy also the rectum, and we put the stent also in the rectal side. And so the patient is totally dry and covered in the same moment if we put it inside it. So our results is, for stricture we use it also very well. For closing of fistula, you see our results, and we use it for closing of ureteral fistula, 91% at 60 cases. Urethral bridging in a benign part. In a benign, it's growing itself together, and you have no problem, 100% at 8 cases. And if you have cases after radiotherapy or tumor, they can't come together, but they bridge it, and we have totally closing and waterproof of the gap in 100% in 21 patients. And that's why we recommended that stent for problematic cases, in fistula cases, in complete damaging of ureter in benign cases, and it is simple and easy to put it, and following border studies will follow, and then we will see also the long-term results of that kind of treatment. Thanks.